registered to receive the continuing education credit for attending the ECHO sessions, you can do so through creating a profile and registering for each session on the Southeast AIDS and Education Training Center. The link for today's session is here on the screen in addition to the QR code. Just know this is not a requirement for you to participate in Project ECHO. However, if you do want to receive that continuing education credit, you do have to register. What will happen is after you create that profile and you do attend the full session, you will then receive a post-session evaluation via email, and then your certificate will be emailed to you at a later time. Kimber has also included the link to register in the chat. So just a few introductions and announcements. I see that we have had several join since we first started. So again, welcome to Project ECHO today. I am Lindsay Zimmerman. We will be having a discussion from one of our subject matter experts in just a few moments. But in the meantime, if you will please take a moment to introduce yourself in the chat. Please include your name, your role, organization, and if this is your first ECHO session. Kimber has already put in the chat that if you have any technical issues during today's session, please do not hesitate to reach out to her. And so I'm going to give us just a couple of moments to do that. And for folks that may have just joined, just as a reminder that if you do want to receive the continuing education credit for participating in ECHO sessions, you do need to register through the Southeast AIDS Education and Training Center, or the SEAETC. Again, this is not a requirement to participate, but it is required if you want to receive credit. You do have to attend each session. As far as the full duration of each session, once that is complete, you will receive a post-evaluation survey via email, and then your certificate will be emailed to you at a later time. All right, so I'm going to go ahead and pass it off to Dr. Allen. He is going to do a presentation today on substance use and injecting behaviors during and after hepatitis C treatment.
All right. Thanks, Lindsay, for the introduction. So yeah, today we're going to look at things a little differently, look at more of what happens during treatment while for patients who inject injection drugs during treatment and after treatment, and things that we need to look out for and be monitoring for during that process. Next slide. No conflicts of interest to disclose regarding this lecture or seminar. Next slide. Abbreviations. Some of these will be abbreviations in the lecture as well as said out loud. So I want to jump through a couple of them real quick. Injection drug use, people who inject drugs, syringe service programs, hepatocellular carcinomas, HCC, and if I say SVR12 a lot, I'm referring to sustained viral response 12 weeks after treatment. Next slide. We've got a couple objectives today that we want to make sure we address all of them, looking at background, talking about counseling points while on treatment, talking about harm reduction practices, and we also want to make sure we're being able to summarize post-treatment care of people who inject drugs after we're done with the hepatitis C treatment. Next slide. And then you can go to next slide. So let's talk about background first. We want to first address the problem that's of how we got here. The opioid crisis has been going on since the 90s, and it's progressed and gotten worse, and it has slowly led to an increase in hepatitis C patients in the United States. It has become injection drug use is one of the main, most common factors of hepatitis C infections, new infections that are currently documented. Most of them, we would say about 70% of new and infections of hepatitis C are associated with injection drug use. So that's kind of the driving force of why there's still an ongoing perpetual epidemic of hepatitis C within the United States. There's also patients who are people who inject drugs. There's about a 53% chance that they could be exposed to hepatitis C with their practices. And then there's a large range of variability of people who do inject drugs that are exposed to hepatitis C. There's about 45 to 85% chance that they will contract and have a chronic infection of hepatitis C, because is a potential chance they could clear the virus, but over and large, there's a larger percentage chance that they're going to develop a chronic infection. And that's lots of variability in all the studies that I looked at. So I tried to have a big range there. That doesn't really help, but just knowing that when you educate your patients when you first see them, telling them there's risk if they're not already infected. If you're seeing a patient who injects drugs, letting them know of the risk. And we want to promote harm reduction practices going forward. We'll talk more about those in the coming slides. And as you might guess, the younger population, age 20 to 39, I combined two of the age groups together that I found on research sites that showed about 40% or close to 50% of the new infections are in the younger population between 20 and 40 years old. Next slide. So I want to make sure that we talk about what are the risks of not treating patients who have hepatitis C, but who are also injecting drugs. We don't want to exclude those patients because there is evidence out there in these two articles that it's shown that there is detrimental effects to them by and large based on patients who do not have substance use disorders. Comparatively. So these two are basically the same article, but they have it in different layouts. One is the more clinical, and then there's an editorial if you want a shorter read that's more concise. I wanted to have both links there if you wanted to read one of those. But it's basically showing that people who inject drugs have an increased risk of developing cirrhosis leading to hepatocellular carcinoma, HCC. So they looked at different groups. They looked at patients with substance use. They looked at patients without substance use. They looked at patients with cirrhosis and without cirrhosis. And they kind of looked at all those groups to see if there's any consistencies or tendencies in those groups. And what they found is patients with substance use not treated for hepatitis C had a higher risk of developing decompensating liver cirrhosis and hepatocellular carcinoma associated or compared to patients that did not have a history of substance use. So that right there, we can just stop and know that there is a risk higher than patients who don't have substance use disorder, that we need to still treat these patients. We don't need to neglect them because they have these different type of social things that they're doing, that they still need to be treated just as much as anyone else. So that's my first point. The articles also showed that hepatitis C treatment in the substance use group reduced the risk of decompensated cirrhosis in non-cirrhotics, and then in the reverse, if they had cirrhosis and had substance use, that reduced the risk of hepatocellular carcinoma. So there's lots of different back and forth between the two articles. I don't want to get too much in the details, but knowing that there is a reduction and prevention of reducing the risk of HCC and decompensated cirrhosis in these patients. So substance use disorder is a risk factor for more aggressive liver disease, and it should not be a limiting factor for treatment. So that's kind of the takeaway of this. And as the second article shows, the faster the better. Knowing that there are risks associated with patients who inject drugs, we know that there is literature out there and data that backs up that if we don't treat these patients just like we would any other patient without a substance use disorder, they have potential health risks that can exacerbate and elevate quicker. Next slide. So it says during treatment, but we're going to have an evaluation slide first. So let's go to the next slide of evaluating treatment before we start treatment. So the first thing we want to do, I've said it in a previous lecture about 2 years ago, we want to build trust with our patients. If they're skeptical to the healthcare system, we want to make sure that we meet them where they're at. We don't want to judge them. We want to help them, because if they want to help themselves, which I hope they do, we want to help treat their hepatitis C, and we also want to promote things like harm reduction practices. So that's two things that we can do for these patients. So regardless of the treatment setting, recent or active IV drug use, there is no absolute contraindication to treat hepatitis C. So that's the first thing they want to do. The next thing is we want to identify any barriers to treatment that this patient might have to treatment. So that could be homelessness, mental health, incarceration, payer sources, adherence concerns, lack of training for the provider. Like all of these things can be barriers to getting a patient who practices substance use can as to why they can't be treated. So those are things that we can help meet them where they're at. We can help overcome some and try to and do our best to find out ways to help get them treated and as quick as we can. We also want to let them know before we start treatment about the risk of reinfection. So patients who are continuing to use IV drugs, let them know there's a risk of being reinfected and having to start the whole process over if and when we were to be able to get cured. So letting them know that on the front end, and then of course come right behind that with promoting harm reduction practices, which includes needle exchange programs and other type of social support we're going to talk about soon. And then we also want to discuss cure rates and outcomes. We want to talk about what I just mentioned in the previous slide about what are the benefits of overall health of getting rid of hepatitis C, curing the virus, but also knowing long-term complications if left untreated. So those are things I like to explain on the front end as to why I care so much about hepatitis C treatment. Telling them what the long-term risks are if left untreated kind of helps get patients in gear. I try to use the word, we're trying to prevent liver cirrhosis if we're not there yet, and liver cancer. Those are the main two things that I can really get patients' attention with when I'm first counseling them, knowing that this is why you should care as much as why I care as well. Next slide. Now, once we're on treatment, the main thing adherence. The medication is only effective as how often it works. So we want to make sure that they have good routines developed. If they don't have anything already, if they don't have any current medications, maintenance medications they take on a daily basis, we would need to develop or make a routine, whether it be first thing in the morning, which is what a lot of patients of mine do, or take it at night before they go to bed. Either way is fine. I don't care as long as they're able to develop that routine. They can set reminders on their phone, have a calendar. I offer many different ways of how they can set up Pillbox if they want to do that route as well, or they can have an accountability partner, whether it's a roommate or somebody they live with or talk to all the time. Having somebody that knows their own medicine that they feel comfortable sharing that information with can help as well if they don't have a family member in the picture. I try not to overcomplicate it, try to keep it simple. Try to one pill once a day or 3 pills once a day with food. I try to make sure I offer both options if they're both on the table to let them pick a medication that they know is possible for them to take the whole course without missed doses. While they're on treatment, we want to make sure we're monitoring labs. It doesn't necessarily have to be at a week 4 or week 8, but if you want, I like to have patients come back at least one time while they're on medicine, if anything, just to check in, have a touch point with the patient, making sure I know I'm still in their corner, trying to make sure that everything goes smoothly, getting the medication, getting through the treatment course, and of course, reminding them of their cure determination date at the very end, 3 months later, which is the most important one, but also the hardest one for patients to remember to come back to, especially if they've been off medicine for 3 months. That's not in their mind anymore because they know they're done with the medicine. So I try to reinforce that along the way, knowing that, hey, don't forget, we need you to come back 3 months after the medicine to make sure we do indeed cure the virus. We can also offer vaccinations. We talk about that every day or every session in the ECHO about hepatitis B. We could also offer hepatitis A, flu vaccine, any other thing that's offered. But we mainly, I focus on hepatitis B vaccination because we know if a patient who is injecting drugs, we know there's still a risk factor there of contracting hepatitis B. So all the more reason of why I'm going to always offer the hepatitis B vaccine. And then harm reduction practices, safer drug use, safer substance practices, and social support are kind of the main 3 things of how I describe harm reduction act practices. And then the next slide is kind of going to go more in depth. Next slide. So harm reduction, if you haven't been on our echo sessions before, it kind of helps out encourage lifestyle changes in a person who's injecting drugs to do safer injection drug use, which means using clean needles, needle exchanges, and being able to kind of get plugged into rehab programs to kind of work if they're willing and wanting to get off of injection drug use, kind of getting them down that path and helping them on the way. I provided a map here of all of the syringe service programs that are in the state of Tennessee. As you can tell, there's not a bunch of them all across the state. There are in certain pockets, of course, in the major metropolitan areas of Shelby County, Davidson County, and Knoxville. Those are the main areas of where there's the most. But of course, there are some around the area. We always want to promote more of those because we know these are not the only places that people inject drugs, and we want to always get the word out. Now, syringe exchange programs. It's a needle exchange program, but that's not all they do. So they provide access to clean needles, but they also provide a way to dispose of needles. So that's also a key of knowing how to dispose properly of used syringes. And they also provide overdose kits if that is an option, naloxone as well. Showing them how to use those things if they're still engaging in injection drug use and slowly trying to get them away from those practices. Now, people who use sterile syringe programs are more likely to enter a treatment program, substance abuse program, than stop injecting drugs than those who do not use a sterile service program. So there's data behind this to show that these programs do work in helping patients kind of move away from those social factors that they engaged in, and to kind of get them to a better overall health outcome on the back end. New users of a syringe service programs are 5 times more likely to enter a drug treatment program than those who do not, and they are also people who inject drugs and who have used an SSP are regularly and nearly 3 times more likely to report reduction in injection frequency, and then those who are never used an SSP. So there's evidence to show that these programs do work. It's more about building up more programs throughout the state in places that need these facilities and need these programs to help out more patients to hopefully prevent new hepatitis C infections from sharing of needles that are dirty. And of course, last point, advocating for mental health services also something that we want to bring up as far as harm reduction as well, if applicable for that patient. Next slide. So now that we've finished the course of hepatitis C treatment, now what do we do? Next slide. So once they've finished the course, that's great. And the hardest part is getting them to come back one more time 3 months later and telling them that the cure rates for hepatitis C for person who injects drugs versus a person who does not is still above 90%. So there's no difference, no delineation between those two groups. It doesn't change the overall health outcomes of curing the hepatitis C, which is great. Let them know that. Continue to support harm reduction practices, kind of check in on them, and also promote liver health. That includes reducing alcohol and tobacco, as well as finding if there's any other things that could be causing liver injury associated with. We got rid of the hepatitis C, and removing other risk factors associated with liver damage is also something I like to counsel on. And then the last point here, now this is one that I like to really emphasize for patients who continue to inject drugs even after we've cured them, but they're still on the path of trying to kick that habit. Letting them know the risk of reinfection, one, hepatitis C, but also there's other infections. So that includes hepatitis B, HIV, bacterial infections. So bacterial infections, those can be get in the blood, and we can call that bacteremia, and that can lead to endocarditis, which is an infection in the heart. So lots of other infections that can lead to more acute things as well, and not just hepatitis C. So it's not just hepatitis C we're trying to prevent. We're trying to prevent these other infections as well that could become more acute things, like having to go to the hospital for endocarditis or something like that. So that's something else to have in your hat, to remember that we're not just trying to prevent hepatitis C reinfection. We're trying to prevent other infections from even entering the clinical picture as well. Next slide. So then, in conclusion, we want to first, as I've previously stated, we want to meet them where they're at. We want to understand where they're at. Are they looking to kick the habit of IV drugs? Can we push them down that route into harm reduction practices? But we still don't want to deny or delay treatment depending on where they're at. We don't want to hold up any barriers there, because we know, based on what I mentioned in the beginning, that we know there's still increased risk of liver damage outcomes overall in those patients, even more so than patients who don't have a substance use disorder. Be mindful of the social factors, treat them like any other patient, help them overcome barriers, and also promote lasting lifestyle changes. So that includes promoting liver health, also using the harm reduction acts, harm reduction practices, not acts. So everything we talked about can be found in the hepatitis C guidelines on the website. We can also, persons cured of hepatitis C no longer transmit the virus to others, which is a plus, but that also means that they cannot transmit it to anyone else. So I would say that treating people who inject drugs for hepatitis C is also benefiting public health because they're no longer able to transmit it to others. So think about that as far as a cascade effect of treating one person can help prevent future infections as well. So letting your patients know that this is what we're trying to do overall from a public health standpoint. Several health models have shown that even modest increases in successful treatment of hepatitis C among people who inject drugs can decrease the prevalence and incidence overall of hepatitis C. So that's huge. And so that's what we should overall, as healthcare providers, promote to our patients, and our goal as to why we want to treat hepatitis C in all of our patients who are infected. So the elimination hepatitis C among people who inject drugs will also require scaling up of harm reduction services, promoting those things, and preventing the risk of reinfection from those practices. So, successful treatment and cure benefits the health, public health overall, and so therefore these are kind of reasons of why we should always screen our patients, treat our patients regardless of where they're at socially. Next slide. Questions. Thanks, Kimber, for adding links.
All right, Dr. Allen, I'll ask you one. Okay, so when you have patients who utilize, are uninsured and we're potentially going to be utilizing patient assistance programs, is there any issue with, let's say you have a patient that successfully goes through treatment and unfortunately they get reinfected due to substance use? Is there any issue with getting them reapproved for retreatment when you're using those patient assistance programs?
From my experience, I've only had that happen once. They were previously treated and cured somewhere else and they came to us. I didn't have any proof of that. I just took their word for it. But I believe there's a spot on the form where you say previously treated. And so I'll mark yes, but I'm also going to put out to the side reinfected. I'll say cured, reinfected. So I just put in a little asterisk beside it saying, yes, they are treatment experienced, but I don't want them to assume they're treatment failure. So I want to make sure I distinguish that they were treatment experienced, but they got cured. So it's one of those things where it's a catch 22 almost. You could say they're treatment naive because you know it's a new infection, but you also don't want to withhold all information and say that, well, they have taken medicine before, but we believe this to be a new infection. So we can always have that conversation with the drug company. I would say I would have more issue with an insurance company explaining that versus the drug company. I feel like they're less inclined about all the clinical aspects of it, more about making sure that they're just financially eligible to receive medication for free from the drug company. But yeah, great question, and that same question could go for insurance companies explaining reinfection would be considered still treatment naive, as we've said in the past, versus treatment experience. Because once you say treatment experience, the insurance is automatically going to think you're saying treatment failure. So be very careful with the terms that you use on the PA forms, and make sure you explain out what you're trying to say. If you do click that box saying treatment experienced, when you know or you're pretty confident this is a reinfection versus treatment failure, because the treatment cascade is very different for those two things. Because treatment reinfection would just be starting with a first line agent again, versus treatment experience would be going to salvage therapy. So yeah, very very specific on making sure I use my words and terminology correctly when dealing with insurance company and as well as the drug company. Great question.
Thank you. I think it's great to have those conversations, as I think, with our uninsured population, some folks may have the mindset that, you're only able to be approved one time. And so, that's definitely an important conversation to have. Does anyone
Yeah,
else have any other questions?
while they're formulating their questions, yeah, to go along with that, a lot of patients will be worried when they do come back to their SVR12. They'll ask me, "Well, what happens if it didn't work?" And I said, "Well, we'll worry about that if we have to worry about that." So I try not to make them think about that we've got to go to plan B unless we have to go to plan B. So I usually don't bring up that there is a second option until I have to entertain it because I want them to be cured on the first time. I really don't want them to know there's a second shot because I don't want them to mess around and mess up the first one. I want them to focus on the first go around, get cured, and that way we don't have to entertain a second go around if we don't have to. But yeah, people do ask that all the time. What happens if it doesn't work? And so I try to put their mind at ease. Say, and there's the plan. I just don't want to use it if I don't have to.
And as Dr. Allen pointed out, Kimber has dropped some great links in the chat. So our colleagues over in the Syndemic program, they have great resources online for more information about the SSPs in Tennessee, the application process. If your agency is interested in potentially becoming an SSP, can be found on that website. Um, Also, there are additional handouts, such as a compassionate overdose handout that can be given. Also, I believe there is some naloxone information that's included. There's a overdose prevention and response toolkit that's included on there. There's just really great resources on their website. And you can also email ssp.health@tn.gov if you do have more information or more questions about an SSP, or if your agency is questioning the process for becoming an SSP. Anyone have any questions before we switch over to case presentations?